So next speaker is Riley KESSLER, who's a resident at CHOP, and she's going to talk about our next little layer, retrospective data analysis. If you look, now we've kind of outlined the entirety of the lived experience of Syngap. Now takes this next step and see how can we basically take all the data out there on Syngap and analyze that. Riley.
All right, thank you guys so much for having me. It's an honor to be able to present with everyone else here today. So building off what we've already heard about, my project was focused on looking at all of the patients that have previously been published in the literature to see what they can teach us about the spectrum of disease. In order to do this, we identified patients with either pathogenic or likely pathogenic variants. Then we assigned them HPO terms based on the clinical phenotype that was reported. And then we were able to use our lab's computational phenotyping approach to define the phenotypic spectrum. So let me take a step back and talk a little bit more about what I mean by this computational phenotyping approach and the HPO. So we can imagine that different clinicians or researchers may describe similar phenotypes with different terms, and this is because they have different focuses to their work and may think about things on different levels of detail. But we need a way to step back and bridge that difference so that way we can really see the similarities between individuals. And this is where the HPO, or the human phenotype ontology, is helpful. It provides us a common language, but it also organizes terms into a tree-like structure that allows us to see the relationships between terms. So for example, if we have two patients, one with absence seizures and one with generalized onset myoclonic seizures, I would assign each of them the base HPO term based on the description in the paper. But in addition to that, they would all be assigned all of the higher order, less specific terms up into the root of the ontologic tree. And this is a process we call propagation. And through this process, both patients would be assigned the term generalized onset seizure. And now that they both have the same term assigned to them, we can see that similarity between the two patients. All right, so now that we have an understanding of what this process is, let's talk about the cohort. So we ended up with 197 patients, the majority of whom had protein truncating variants. And we can see all of the variants here mapped along the gene. And the height of each vertical line represents the number of recurrent variants at a given locus. And overall, we had 146 unique variants. Another way of looking at this is by looking at the number of variants per exon. You can see that exon 8 and exon 15 had the most number of variants. One thing I thought was interesting was that we had 12 unique missense variants, and 6 of the 12, or half of them, were located on exon 8. One of the simplest things we can do with this type of analysis is look at what are the most commonly reported phenotypes across the cohort. I'm just going to zoom in on the top 10 here to make this a little easier to digest. And so here we see things that we very much expect, things like intellectual disability, developmental delay, and autism. We also see features that are more unique to SYNGAP1, things like behavioral issues, aggressive or impulsive behavior, and sleep disturbance. I also thought it was interesting that we see abnormality of the face and abnormality of the skeletal system here. And that represents that across the cohort, there was a smattering of different dysmorphic features that were reported. And when we used our propagation technique, these more umbrella terms kind of rose to the top as some of the more commonly reported phenotypes. We can look at the age at which patients are achieving their developmental milestones. And here we have the cumulative percent of patients who are achieving their milestones by a given age. Specifically, we're looking at sitting, walking, and speaking a few words. The vertical dashed lines represent the age at which 75% of the typically developing population is expected to achieve these milestones. And overall, our cohort was achieving the milestones later than their typically developing peers. We can look specifically at the green line, which represents speaking a few words. The median age in our cohort was 29 months, and that's compared to 18 months that 18 months is the age at which 75% of the general population is expected to achieve that milestone. Something else we can do with this type of analysis is look at correlations within the cohort. So here we have a graph that's looking at comparing patients with missense variants to patients with protein truncating variants. The y-axis represents statistical significance, with red dots representing significant associations, And the x-axis represents the magnitude of difference in the frequency with which phenotype is reported between the two populations. So if we look at the group with missense variants, phenotypes like expressive language delay, abnormality of the skeletal system, and ataxia are enriched compared to the group with protein truncating variants. And I'll take a step back here and recognize that this is a preliminary analysis. The relatively small number of patients with missense variants allows us to be susceptible to bias, and so this is something we will continue to reevaluate as hopefully we're able to classify some of our variants of unknown significance and add to the number of patients with missense variants. Similarly, we can look at clinical subgroups. So here we're comparing patients with and without autism and with and without epilepsy. In the autism group, phenotypes like gait disturbance, developmental regression, and constipation were enriched. And in the group with epilepsy, we saw phenotypes like global developmental delay, abnormality of movement, and sleep disturbance. And again, I'll recognize that this is a preliminary analysis. We can imagine that a paper that is reporting on autism may also be more likely to report on things like developmental regression and constipation, and that would also affect these data. So these types of analyses will be stronger when we have better data standardization, and that's something that will be talked about in the talks following mine. Lastly, I'll talk about the seizure types in our cohort. Overall, we had 70% of our patients were reported to have a seizure of any type. The majority of those, 58%, had generalized onset seizures, and of those, 92% had absent seizures. We've already heard that two seizure types that are more unique to SYNGAP1 are absent seizures with eyelid myoclonia, and those were present in 38% of our cohort, and myoclonic atonic seizures, which were present in 13% of our cohort. Lastly, we can look at the age of seizure onset. So here again, we have a graph showing the cumulative percent of patients who have had their first seizure over age. And the vertical dashed line here represents the median age of onset, which was 24 months. And that's on par with other studies in SYNGAP1, which have suggested that the first seizure is usually in the second or third year of life. So overall, we were able to review patients previously published in the literature to see what they can show us about the phenotypic landscape in SYNGAP1 and demonstrate how we can utilize our HPO-based analysis. As I mentioned, these types of analyses will become stronger when we have better data standardization, which will be talked about in the following talks. And will also be stronger when we have an increased number of missense variants, hopefully by further classifying our variants of unknown significance. Thank you.